Welcome back to the Deep Dive. Today, we are getting stuck into what is, I think, arguably one of the most critical, high-stakes areas of professional practice.
Absolutely. It's that point where ethics, the law, and clinical urgency all just collide.
And if you're preparing for an exam like the MSRA SJT, this topic cluster, we're talking cultural awareness, equitable care, avoiding discrimination. This is an absolute goldmine of high-frequency questions.
It really is. And the sources we've pulled for this, they're not just academic theory. This is the bedrock of UK medical professionalism. We're looking at extracts from the GMC's Good Medical Practice 2024.
It's a new one, yeah.
The new one. And mandatory NHS guidance like the Accessible Information Standard, or AIS, and even core strategy docs like Core 20 PS US 5.
What I think is brilliant about today is we're taking all that, all those dense legal texts, the Equality Act, nice e-guidance, and we're just boiling it down.
Distilling it.
Yeah, distilling it to maybe 5 or 6 key actions that are the ones that consistently score the highest in these really complex scenarios. So our mission is to give you the fastest, most defensible route to, well, professional success.
And we have to move beyond just definitions, right? This is about the action plan. The moment-by-moment decisions you have to make when time is tight, beliefs are really firm, and communication is breaking down.
You need the shortcut.
You need the shortcut to the safest and, crucially, the most defensible professional behavior.
Okay, let's unpack this. Specifically for high-yield SJT success, making sure we get into all the depth you'll need. So let's just dive right in with a classic scenario, one that really shows the tension here. It forces you to juggle urgency, autonomy, and equity all at the same time.
The classic triad.
Exactly. So picture this. You are working in the emergency department. You have an adult patient. They're hemodynamically unstable, maybe a rapid bleed, and they need an urgent, potentially life-saving blood transfusion.
High stakes already.
Right. And as you go to start the consent process, they clearly indicate, maybe with gestures, a few halting English words, a really strong faith-based refusal of blood products.
Okay.
And to make it even more complicated, they speak very limited English, and their partner, who's obviously highly anxious, steps right in and says, "I'll interpret, I can do it," because they just want to speed things up.
That is the perfect storm scenario, isn't it? I mean, you've got the immediate threat to life. That's the urgency.
Yep.
Then you have the non-negotiable need for autonomy. This patient, who you have to presume has capacity, is refusing treatment.
And the communication barrier, a huge one.
A massive communication barrier. If you accept the partner's help, you are taking a colossal risk. The patient's refusal. Could it be coerced? Or are you sure the complex risks of not having the transfusion are being translated accurately? Probably not.
And all the while, the clock is ticking. The temptation for a stressed junior doctor is always to take the path of least resistance. Yeah.
Use the family interpreter.
Exactly. It solves the communication problem instantly. Yeah. But we know, and this is key for the exam, that's often the lowest scoring action because it's sacrificing safety and legal compliance just for a bit of efficiency.
It's the point where capacity, communication, and cultural respect all meet, and they often clash. The legal standard demands that consent must be valid.
Right. What does valid actually mean here?
Valid consent means the patient has to fully understand the material risks, the benefits, and the alternatives. And without professional interpreting, you just can't guarantee that understanding. It's often impossible.
So given all those immediate temptations, what is the core professional truth that should override everything else?
You know, what's really fascinating here is the core truth for all of these scenarios is that the high-scoring SJT actions, they always require proactive adjustment.
Proactive, so doing it before it becomes a problem.
Yes, proactive adjustment and shared decision-making, which has to be supported by professional communication. That is the only way you can ensure care is lawful, equitable, and timely.
So even in an emergency, you're saying the professional duties like managing the risk of invalid consent, they come first.
They have to. It might mean a managed delay. Stabilize the patient while you urgently get that professional support. The default action is always professional help, not convenience.
That sets the stage perfectly. But why? Why is this particular cluster cultural awareness, equity, discrimination, why is it tested so relentlessly in the SJT? It can feel like soft skills, but it's clearly treated like a major clinical decision.
Because it is a major medical decision. It's fundamentally linked to your legal and your professional accountability. The reason this is rated high frequency and must know is that it tests 3 key things.
Okay.
First, your adherence to your GMC duties. Treating patients fairly, prioritizing by clinical need. Second, it tests your awareness of the law, the Equality Act, the Accessible Information Standard.
And the third?
Third, it tests whether you actually understand that your professional role is to remove barriers for patients. The exam rewards behavior that isn't just ethically sound, but is the most legally defensible action you can possibly take. It minimizes risk for everyone.
Let's focus on a concept that causes a lot of confusion, I think. The difference between equality and equity. For a lot of people, those words are interchangeable. But for the NHS and for SJT scoring, they mean fundamentally different things.
This distinction is not just semantics, it can be a matter of life and death. So, equality. Equality means treating everyone the same way.
Like giving every patient the same 15-minute appointment slot.
Exactly. Or the same standard paper leaflet. It aims for sameness. But let's say patient A has high health literacy, speaks fluent English, and patient B is a BSL user and has low literacy. Giving them both the same leaflet is equal, but it results in an unsafe, totally inadequate outcome for patient B.
Right, because patient B started with barriers that patient A didn't have.
Precisely. Equity means you recognize those differences and you take proactive steps to remove the barrier.
So for patient B, that would be what?
It means extending their appointment time to get a BSL interpreter in, or providing a BSL video explanation, not a written leaflet. Equity is about making sure the safest clinical option is genuinely accessible and understandable to every single person.
So if you fail to address those access barriers, language, literacy, culture, you're failing the duty of equity.
And that failure introduces massive clinical risk. It often leads directly to invalid consent or a delayed diagnosis.
So the whole treat everyone the same equality approach, if you apply it blindly, it actually leads to unsafe, discriminatory outcomes.
Absolutely. The system and the exam rewards doctors who implement equitable adjustments, and the clinical risk is severe. If you don't meet these standards, you are risking invalid consent, you're breaching your professional duties, and you're potentially exposing yourself to legal liability under the Equality Act.
Okay, let's anchor all of this to the non-negotiables then, because in an SJT dilemma, you have to immediately refer back to the legal and professional duties that trump everything else.
We use two main anchors. The first is the Equality Act 2010, and the second is the GMC's Good Medical Practice 2024.
Let's start with the Equality Act.
The Act established 9 legally protected characteristics. These are age, disability, gender reassignment, marriage or civil partnership, pregnancy and maternity, race, religion or belief, sex, and sexual orientation.
And it's not enough just to know the list, is it? The SJT tests 2 different forms of discrimination. Direct and indirect. Can you just clarify that distinction for us?
This is vital. Direct discrimination is the easy one to spot. It's treating someone worse simply because they have one of those protected characteristics.
Give us an example.
A doctor refusing to refer a patient for fertility treatment because they are in a same-sex relationship. That's unlawful direct discrimination based on sexual orientation. Clear cut.
Okay, so what about the more subtle one? The one that's often built into the system. Indirect discrimination.
Indirect discrimination is where so many of the systemic SJT failures happen. This is when you have a rule or a policy or practice that applies to everyone in the same way, but it disproportionately disadvantages a group of people who share a protected characteristic. Like a new fast-track, digital-only clinic registration system. The policy treats everyone the same, that's equality, but it indirectly discriminates against, say, older patients, which is age, or those with severe learning disabilities, which is disability, who just can't navigate those complex digital platforms.
So the policy wasn't designed to be malicious.
Not at all.
But its effect is to create an unfair and inequitable barrier.
Exactly. And the high-scoring action there, according to the Equality Act, isn't just to solve the problem for that one patient in front of you. It's to raise the systemic issue and provide a reasonable adjustment, like offering a telephone or face-to-face registration option right there and then.
Let's move to the other anchor.
Yeah.
The GMC mandate on personal views. This can be a really uncomfortable area for some candidates.
It is the second non-negotiable. The GMC is explicit. It says you must treat patients fairly, and you must not refuse or delay treatment because you disagree with their lifestyle, their personal choices, or their beliefs.
So prioritization has to be purely clinical.
Purely based on need. A classic SJT trap will involve a patient with, say, a history of drug-seeking behavior or non-adherence, where the doctor feels frustrated or judgmental. Your feelings are irrelevant. Your professional duty is to prioritize their care based on their clinical need, not your personal stance. You just can't impose your moral judgment on a patient's right to care.
And what about communication? That's so often the immediate barrier. Let's talk about the Accessible Information Standard, the AIS.
Yeah.
This isn't just a nice to have, is it?
No, absolutely not. It is a mandatory legal requirement for all NHS organizations and publicly funded social care in England. It sets out a formal process that organizations must follow.
What's the process?
You can think of it as a 5-step cycle.
Yeah.
First, you identify. You have to proactively ask about communication needs, language, BSL, format, anything.
Then what?
Second, you record. Document that need clearly in the patient's record. Third, you flag it. You use an immediate alert, like a pop-up or an icon, so the whole team sees it.
Okay, identify, record, flag.
Fourth, you meet the need. So you provide the adjustment book, the interpreter, get the easy read leaflet, and fifth, you review. You regularly check if the need is still there or if it's changed.
So that means if a patient arrives who clearly needs a BSL interpreter and there's no flag on their file, the top scoring answer would involve not just getting the interpreter for them now,
Right.
but also making sure that flag gets put on the system for the future.
Absolutely. High-scoring answers always address the immediate patient need and the system failure that allowed it to happen. You have to fulfill that record and flag duty of the AIS.
And within that AIS framework, the rule on interpreting is probably the most critical, high-yield fact to know.
It is. The core rule is this. You always offer and provide a professional interpreter, one that's paid for by the service, especially for complex things, consent, capacity assessments, sensitive information.
And relying on family.
Relying on family, friends, or especially children is the #1 low-scoring trap. It's a huge risk for coercion, for inaccuracy, and for breaching confidentiality if that family member starts acting as a gatekeeper.
But I hear this argument a lot from candidates. They say, but what if the family member is a great interpreter and the patient really trusts them?
The professional standard holds fast. Even if they are highly competent, the risk of coercion, especially in a high-stakes setting like the unstable patient we started with, is just too high. Family interpretation is only okay in documented, informed exceptions.
Like what? A very minor update.
Maybe a very minor routine update, but never for critical decisions. For any complex consent, you need professional support. And delaying slightly to ensure that professional communication is almost always professionally safer than rushing ahead with what could be invalid consent.
Okay, lastly in this section, we have to talk about respecting beliefs, especially when it involves refusing treatment.
Right. Respecting beliefs under GMC guidance is an active process. It's not passive tolerance.
What does that mean, an active process?
It means you actively explore the clinical impact. You ask about modesty requirements for an examination. You check if a scheduled treatment clashes with fasting or prayer times. And crucially, you discuss refusal of life-saving things like blood products.
And if a patient with capacity refuses that treatment for religious reasons?
Your duty is threefold. First, you confirm they meet the 4 criteria for capacity. Can they understand, retain, weigh, and communicate the decision? Second, you make absolutely certain they fully comprehend the risks of refusal and any safe alternatives. And third, you must respect their decision, and you document the whole process meticulously.
So the SJT is testing whether you honor that informed choice, even if you, as a clinician, totally disagree with it.
Exactly. Any attempt to coerce or unduly persuade them will score extremely low.
Right. That's a lot of individual steps to pull together in the heat of the moment. Let's try and combine all of this into a unified, practical framework that you can apply instantly.
This is it. This is the practical, step-by-step method that pulls all that guidance into high-scoring actions. We call it the unified 5-step approach for culture and equity.
Okay, let's break down the 5 steps.
Yeah.
And I'm going to challenge you on the practicality of each one, especially when you're under pressure.
Go for it. Step 1. Ask first. Don't assume.
Simple enough.
You have to proactively ask about culture, faith, language, communication needs. High-scoring answers always start by eliciting the patient's perspective. It stops you from stereotyping and it uncovers needs you wouldn't have known about, like fasting or modesty requirements that could completely change your clinical plan.
That makes sense for the start of any conversation. But step 2, immediate adjustment. This is where theory hits the reality of resources, isn't it?
It is. Step 2, immediate adjustment, the equity duty in action. This is where you arrange professional support now.
So professional interpreter, BSL support, chaperone, easy read formats, a longer appointment slot.
All of it. And the action has to be immediate. If the patient is unstable, your priority is to stabilize them while urgently getting the professional interpreter. But that adjustment has to happen before any critical conversation or consent.
Okay, but here's the pushback. What if the professional interpreter is going to take 3 hours to get, and the patient needs treatment in the next 2? This is the pressure point. Are you saying we delay care?
That is a great challenge, and the answer is about risk management. If the patient is unstable, you perform life-saving interventions that don't need immediate consent, like managing their airway or breathing. Basic life support.
But for the specific thing, like the blood transfusion.
For treatments requiring specific consent, even urgently, if the interpreter takes 3 hours, you have to find a way to manage that risk for 3 hours, or look for a valid, documented exception, like a confirmed loss of capacity. Delaying care to ensure valid consent, as long as the patient is stable, is professionally defensible. Proceeding without valid consent is not. You have to prioritize the legally safe pathway.
Okay, so what's step 3?
Step 3. Shared decisions and teachback. Confirming understanding. This comes straight from NICE guidance. You use decision aids, you present options and risks in an accessible format, and then, critically, you use the teachback method.
So you ask the patient to explain it back to you.
Yes. Ask them to explain the diagnosis or the plan back to you in their own words. If they can't do it, then you have not met your duty to ensure understanding, and the consent is probably invalid.
That's a powerful shift. It moves the responsibility from just the patient understanding to the doctor having to confirm that they've understood.
It does. Now, step 4. Stop bias address barriers. This covers both the small and the big failures.
Micro and macro.
Exactly. Micro. If you see a colleague make a derogatory comment, you must stop it immediately, courteously, but clearly. Macro. If you see a systemic access failure, like only digital forms being available, which is indirect discrimination, you immediately offer an alternative, and then you raise the system issue with management. Dedic's it.
That step involves immediate confrontation and then formal escalation. It's a huge professional challenge for a junior doctor. How do you prioritize stopping the harm versus escalating the colleague?
You always prioritize the immediate harm and the safety of the patient first. Stop the behavior. Then you can address the colleague separately, professionally, away from the patient, and then you formalize it. You escalate via your senior or an incident report. Ignoring it is never an option. Immediate intervention is mandatory.
Okay, and the final step.
Step 5. Document and flag. Creating the audit trail. You record everything: the preferences, the agreed safe plan, the rationale for your adjustments, why you accepted a decision. And most critically, if you identified a communication need in step 1, you must apply that AI's flag so the whole team continues to meet that need. That's your defensible audit trail.
So the sequence is: ask what they need, give it to them, check they understood it, deal with any immediate prejudice, and then record the whole thing for continuity. That really does cover all the legal and professional governance.
Right. But under exam conditions, that 5-step plan could just become a blur. We need the tools that make it stick, that ensure instant application. Let's get into the memory hooks.
Absolutely. The brain under stress works best with short, sharp mnemonics.
So what have you got for us? For managing scenarios with beliefs and complex consent, we use the FAITS mnemonic. It walks you through the consultation loop.
Okay, FAITHS. Break it down.
F is for find preferences. That's step 1, ask first. A is arrange support professional interpreter, chaperone. Step 2,
Right.
A is for inform risks. Shared decision making, step 3. T is try alternatives. You discuss safe substitutes if they refuse something.
Makes sense. H.
H is honor choices. If they have capacity, you must respect their refusal. And S is summarize the plan. You document and flag it. Step 5.
Faith S. That's a really effective way to structure that ethical discussion when a patient declines something vital. What's next?
Next, for challenging bias or discrimination, you see, we use FAIR.
FAIR.
Find the facts. What specifically happened? Address the behavior. Stop it immediately. Include adjustments. Restore the patient's access or dignity. And record and refer formal escalation.
And finally, what about those big system-level failures? The systemic inequity questions.
For that, we rely on the NHS Core 20 PLS5 strategy, the national framework for tackling health inequalities. Core 20 is the most deprived 20% of the population, plus 5 key clinical areas.
And the strategy for applying it.
It's all about T3.
T3.
First T is target. You identify the specific Core 20 postcodes and any local PLUS groups like homeless people or specific minority groups.
Then you.
Second T is tailor. You implement barrier-busting actions designed for those groups. So evening clinics, transport vouchers, community health workers, tailored information.
And the third T.
You track. You have to measure and audit your outcomes, your access rates, patient experience, specifically by deprivation, to prove your intervention actually worked.
I really like that visual analogy you mentioned earlier. It makes this so clear. Equality is just making the curb a bit lower everywhere?
Yeah.
But equity, the T3 approach, is about putting a functional ramp exactly where that core 20 patient needs it most, at the entrance to the digital clinic,
Yeah.
and then marking that ramp on the map with the AIS flag so everyone knows it's there.
That's it. It just clicks, doesn't it?
It really does.
Yeah.
Okay, now let's get into the 4 core patterns the MSRA uses to test all of this. If you can recognize the pattern, you instantly know what the priority action should be.
Absolutely. Let's start with pattern 1, the urgent language barrier.
What's really being tested here?
It's testing your prioritization of professional communication over convenience or speed. It's all about securing valid consent.
And the best action.
You immediately stabilize the patient clinically, if you can. At the same time, you urgently arrange a professional interpreter. That's step 2. You tell your senior immediately what's happening and about the planned managed delay to get that valid consent. You have to postpone the consent discussion until the interpreter is there.
And why do the trap answers lose marks?
Using family is the big one. It risks invalid consent. And delaying getting the interpreter until the next shift or something, that risks the patient deteriorating and is a system failure.
So even if the patient is unstable, the duty to stabilize and the duty to seek proper professional consent, they run in parallel. An invalid consent is a risk you just can't tolerate.
Almost never. Now, pattern 2, the discriminatory colleague.
Here, they're testing your mandatory duty to act immediately when you see prejudice.
Yes. And your duty to support the patient and escalate using those fair principles.
So an example would be a senior colleague making a derogatory remark about a patient's race or sexual orientation, or refusing to engage properly because of a patient's addiction history.
Exactly. And the best action is step 4. You stop the remark immediately, professionally, maybe away from the patient if you can. Something like, that language isn't acceptable. We need to focus on the patient's clinical need.
And then?
Then you make sure the patient is supported, and you formally escalate the colleague's breach of GMC guidance via your senior and the incident reporting system, DATX.
Why do the traps lose? Why can't you just ignore it or tell them to be kinder later?
Ignoring it, waiting, or just having a quiet word. It fails your duty to raise serious concerns. The GMC says you have to challenge unacceptable behavior.
I think candidates find this terrifying, challenging a senior. But the SJT is testing the professional ideal.
It is. And the ideal is always patient safety and dignity first. Hierarchy second.
Okay, pattern 3. The refusal based on beliefs. The focus here is on capacity assessment.
Yes. This is testing whether you can uphold patient autonomy, even for life-critical decisions, as long as you have confirmed they have capacity.
The classic example being a Jehovah's Witness refusing a life-saving blood transfusion.
That's the one. Your best action is to conduct a rapid but thorough capacity assessment. Can they understand, retain, weigh, and communicate? You exhaust all the alternatives, like non-blood volume expanders. You fully explain the risks of refusal. And then you respect their decision.
Even if it leads to their death.
Even then. And you document why you respected it. You write, patient retained capacity and understood the material risks, including death.
And the low-scoring options are coercion.
Coercion, ignoring the refusal, trying to involve the courts without a very strong argument that capacity is lacking. All of those score extremely low. A patient's right to refuse is legally absolute if they have capacity.
That emphasis on the 4 components of capacity is so key. You have to document the evidence for why you think they have it, especially in a situation like that.
You do. Okay, final one, pattern 4. The systemic access failure. This is about inequities.
So this is testing Core 20 PLUS 5 and the duty to remove those systemic barriers, the indirect discrimination.
Exactly. The scenario might be a low uptake of cancer screening or vaccinations in a specific deprived Core 20 area. Maybe because clinic times are inconvenient or the information isn't culturally tailored.
And the best action here is the T3 approach we talked about.
Yes. You target the specific deprived areas. You tailor the delivery move clinics to community centers, offer evening slots, provide BSL or easy read info, and you track the uptake to prove it worked.
So what's the trap answer here?
Just sending out more of the same generic leaflets. That's equality, not equity. Or just waiting for some national policy to change. That fails your immediate duty to tailor care and actively address the health inequalities in front of you.
The ability to shift your focus from just the individual patient to the wider system problem.
Yeah.
That's what makes a high-scoring candidate.
It's the difference, absolutely.
Okay, let's dedicate some serious time to the trap answers because these often look like common sense or just being polite, but they really compromise professional standards.
Yeah.
I want to analyze why candidates pick them and why they fail so badly.
The traps feel efficient, they feel polite, or they feel easy. But they all violate one of the legal or professional anchors we've discussed.
Let's start with the big one, trap 1. Ask the family or a child to interpret. Why is it so tempting?
It gives you instant communication. It avoids the delay of booking a professional. It feels like a quick fix.
But why does it fail?
It breaches the mandatory accessible information standard. It risks profound coercion. The partner might hide information or force a decision. And it risks inaccurate translation of complex risks. All of that leads to invalid consent. It's a non-negotiable failure of best practice.
Okay, trap 2. Ignore the offensive comments to keep the peace, especially if the colleague is senior. The temptation here is obvious.
You want to avoid confrontation. It's socially and professionally uncomfortable. You want to keep the team harmonious.
And the failure.
It breaches your GMC duty to raise concerns. It allows harm to continue. Your silence implies you accept it. The duty to protect the patient's dignity and challenge unacceptable behavior is immediate and absolute. It doesn't matter how senior the colleague is.
All right, trap 3. Give the same standard leaflet or explanation, but just repeat it louder or slower.
The temptation is that it's easy and fast. You feel like you've done something, you've handed out the information.
But it fails because
It completely ignores the access barriers, disability, literacy, language. It fails the equity duty, our step 2, immediate adjustment. If the patient needs easy read or BSL, giving them standard English text is pointless, it risks unsafe consent, and it breaches the AS.
Okay. Trap 4. Delay care or change the priority because it's inconvenient, or I disagree with the patient's lifestyle choice.
This one is tempting because of frustration or moral fatigue. You might feel you should prioritize a more compliant or deserving patient.
And it fails because that's an explicit breach of GMC guidance.
Explicit. Care must be prioritized solely on clinical need. Your personal views on addiction, smoking, diet, faith, they must never interfere with providing timely care.
What about trap 5? Run standard 9-to-5 clinics. We treat everyone equally. This feels fair.
It feels fair, it's an application of equality, and it's also much easier to run administratively.
But it fails the fundamental equity duty.
It widens health inequalities. People in Core 20 areas often have less flexibility for transport or taking time off work, so that policy constitutes indirect discrimination because it disproportionately disadvantages people based on things like age or deprivation, which is often linked to race. You have to tailor your access. You have to do the T3.
I've seen another one. Trap 6. Send a vague email to the clinic manager and wait for a response.
Yes. The I've logged it, so it's not my problem trap. It's tempting because it documents the issue without you having to do anything confrontational right now.
Why does it fail?
In situations involving immediate discrimination or a safety risk or an urgent access failure, the highest scoring action requires immediate intervention. Stop the bias, make an adjustment, and then formal escalation through proper governance routes. Seniors, DATIX. A vague email has no accountability, and it fails the duty for a timely resolution.
Okay, let's do a quick check. A rapid-fire round to apply the highest scoring action instantly.
Let's do it.
Right. A patient who is deaf is given written leaflets only. The receptionist tells them BSL interpreters cost too much. What do?
You intervene. Arrange a professional BSL interpreter immediately. That's the AIS duty to meet. You remind the receptionist of the mandatory legal duty, and you escalate the systemic failure and their bad advice via management. That's fair.
A hemodynamically stable adult, who you've confirmed has capacity, declines a specific surgery because of cultural dietary restrictions around fasting times, making them unsafe for an immediate anesthetic.
You respect the decision, confirm capacity, adjust the schedule, or offer alternatives that accommodate their fasting period. That's FAHS.
Yeah.
Then you document the accommodation and your rationale.
Okay. An urgent, non-life-threatening consent needs rearranging. You discover 5 minutes before the slot that a professional interpreter was never booked, despite a known language barrier.
You rearrange the appointment immediately with a professional interpreter booked. Use the time to get the communication right. A delay is better than invalid consent. Then, you flag the missed AIS requirement for the future. That's step 5.
An imaging slot clashes with a patient's essential short prayer time. The radiographer wants to skip them and move on.
You intervene. You offer a short, safe delay or an adjustment to the slot. You accommodate where it's clinically possible, respecting their beliefs, and you document it. You make sure the patient understands why there might be a brief wait.
Final one. You witness a junior colleague openly mocking a patient's adherence to traditional medicine instead of prescribed drugs.
You stop the behavior immediately. That's A for address and fair. You remind the colleague that respect for beliefs is mandatory under the GMC and ensure care is provided professionally. Then you escalate the colleague's behavior to a senior.
That has been a truly comprehensive deep dive. We've synthesized some really complex guidance into a clear, high-scoring action plan. Let's just try and condense it all down into the 3 absolute essentials you must remember for the exam and for safe practice.
Okay. Key takeaway 1. Ask first. Never, ever assume culture, faith, or communication needs. You have to proactively inquire, that's step 1, to identify the need and stop yourself from stereotyping.
Key takeaway 2. Provide immediate professional support and adjustments. That's step 2. And remember, relying on family, friends, or children to interpret is almost always the trap answer. It compromises valid consent and breaches the mandatory accessible information standard.
And key takeaway 3. You have to challenge bias and systemic failure immediately. Prioritize care by clinical need, not your personal preference, that's GMC 101, and ensure equitable access by proactively removing barriers. Remember T3. Target, tailor, track. That's Core 20 PL US 5 in action.
These principles aren't just about scoring points on an exam. They are your professional armor against legal and ethical breaches. They make sure you're operating at the highest standard of patient safety and respect that's mandated by the GMC and by the law. We strongly encourage you to review these frameworks, the mnemonics like FAC tests and FAIR and practice scenarios on these patterns. You can find more detailed revision materials covering all of this and more at pastemssua.com.
And if I can, a final provocative thought for you to take away. In the SJT, and more importantly, in your clinical practice, you are judged not just on what action you chose, but on the defensible audit trail you created.
Say more about that.
You always have to record the specific adjustments you made, the professional interpreter you booked, the easy read format you provided, the fact you confirmed capacity, and the rationale for your plan. Documenting why the action you took was the safest and the fairest thing to do. That protects you professionally, and it ensures patient safety continues across the entire team.
Always record why you chose the safest and fairest path. That's a powerful closing mandate. Thank you for joining us for the deep dive. We'll see you next time.